I would like, I think I'm the only humble surgeon in the room, so sharing our ideas and how we believe to manage HCC with the scientists like the hepatologists, and the only one oncologist I learned. I hope that we'll meet at the end in the same way of thinking for tackling HCC. Well, as we heard from the previous speakers about the estimated annual number of cases, is always it's a huge number, about 700,000, with a mean annual incidence of around 3 to 4%. But in Egypt, actually, it's comprising something like a fourth of the malignancies in Egypt. All new malignancies being diagnosed every year in Egypt. And HCV used to be endemic in Egypt, at least in the past years, and now, after all we've heard this morning and this afternoon and from the previous speakers and the huge efforts being done in our country and the presidential initiatives, it's decreasing. The number is really decreasing. I remember the days when it was 15 and 20% of the population. Now we're down to 7% or 6%. The index indication in this country for liver transplantation, of course, is HCV-related end-stage liver disease, with the second leading indication for transplant being HCC. In Egypt, up till now, cadaveric liver transplantation is not implemented, although the law allows it, and it's within the law, but it's not yet implemented for different reasons, logistic reasons, financial reasons, infrastructure reasons. So LDLT is the only option for patients in our country who are in need for transplantation. Extending Milian criteria, or what we call extended criteria as an indication for transplantation, is not universally accepted, but we in this country, as we heard from the previous speakers, that we are faced every day by HCC cases who are really young and in the 20s, 30s, and 40s. So we are expanding criteria, and we are pushing the envelope when it comes to indication in LDLT for HCC. If we speak about hepatic resection, of course, it's the standard treatment for primary liver cancer at large, and with HCC being the most important. And the EASL AORT guidelines recommend hepatectomy as a treatment option for HCC patient, especially those who have BCLC stage 0, as I'll show you in a minute, or stage A. Although this has been challenged by the East, our friends from China and Japan, and they extend resection to a little bit of advanced HCC, even those with malignant portal vein thrombus, where they are offering them, and we are doing actually the same thing. I think everybody is familiar in this room by this very important, famous roadmap for treatment of HCC, including the patient performance status, the stage of liver cancer, and the stage of liver disease, and allocating a treatment line for each and every, going all the spectrum from very early stage to early stage down to the terminal stage. And of course, as we can imagine, sorry, can I go back? No. Yeah. As we can imagine, the best results will be for the very early stage, and the early stage with a 5-year survival, with a very good 5-year survival approaching 75 to 80%, and as we go down, the survival will get worse, down to 3 months by best supportive care for the terminal stage. This is all the armamentarium we've got for treatment of HCC, the surgical treatment, surgical therapy. We speak about liver resection and orthotopic liver transplantation, and LDLT, local regional treatment in terms of chemoembolization, radiofrequency ablation, radioembolization, all the spectrum, and in between them, this is what we call a bridge or downstaging, the area that both will share, trying to downstage advanced stage cases to be able to resect them or to transplant them, or even to do resection sometimes as a bridge before transplantation. Systemic therapy comes again with the first-line drugs, and now we have the second-line drugs as well, and the best supportive care. And the tools of modern liver surgery for HCC when it comes to hepatic resection is the preoperative assessment, including liver resection, to actually quantify the hepatic reserve. And if we have a good hepatic reserve, we can go for larger resection and extended resections by different modalities, the child classification, the MELD, or even the endocyanin green clearance and different other modalities, or the or we can increase resectability by some maneuvers that have been introduced in the last few years, like portal vein embolization or the radioembolization, which will treat the HCC on one hand and cause with atrophy of the lobe harboring the HCC and hypertrophy of the contralateral lobe, which again could allow us to do resections and even some extended resections. Or the intraoperative maneuver, the different intraoperative innovations that has really a breakthrough in the liver surgery and liver resection over the past 10 to 20 years. And it's not mentioned in this slide, but it would add also the perfection of the technique and the marked advancement in the anesthesia and ICU management. All of this allowed for better outcome of liver resections. This study, which is still in press, compared partial hepatectomy versus transcatheter arterial chemoembolization for resectable multiple hepatocellular carcinoma beyond Milian criteria, that is the extended criteria. And the conclusion of this study was that partial hepatectomy provided better overall survival for patients with resectable multiple hepatocellular carcinoma beyond Milian criteria over conventional TACE. So if we take the decision to do a liver resection in a given case, we need to look on these three pillars for the best outcome possible, which is oncological appropriateness, that the resection of liver tumor to achieve a survival benefit, the host condition and the general health, what we call the performance status of the patient, and the fitness for surgery, and the technical resectability in terms of number, size, and location of the tumor, vascular, to be sure that we're going to leave behind us a good inflow and vascular inflow and outflow, a good biliary drainage of the future liver remnant, and the future liver remnant with a good quantity and quality so as not to go into decompensation. Our group participated by the beginning of 2019 of this study that is being run by the Royal Free in London, and we were asked to introduce all our liver resection in the first 3 months from January to March 2019, and we included 29 patients with 0 90 days mortality, and only 2 cases received blood transfusion. And there are, as we speak, 283 centers in 192 cities and 57 countries participating in this study. And I think by the beginning of 2020 will yield the results. Salvage liver transplantation or repeat hepatectomy following resection for hepatocellular carcinoma in an intent to treat analysis, as you can see from this study, following liver resection for an HCC. If we are confronted with a recurrent HCC, do we go for a liver transplant, what we call salvage liver transplant, or we do a repeat hepatectomy? The conclusion of this and intent to treat analysis was that both strategies ensure similar 5-year survival, overall survival, but the disease-free survival was much better in the liver transplant group versus the recurrent hepatectomy group, and that is a decision that must be shared between doctors and the patient for a recurrent HCC following resection, when both resection and transplant are deemed feasible and available in the country. Now, we always have this in our weekly meeting. When I was attending the weekly meeting and the monthly meeting, when we're faced with the HCC cases, which are plenty, as we heard in Egypt, do we go for resection upfront or a liver transplant upfront? And of course, the availability of organ for liver transplantation is crucial, but we have an LDLT that is available in this country, and we're going to share with you our experience over the past 19 years. And of course, we all, as you all know, the answer for this debate would be how much the liver is cirrhotic and the liver function and the remnant liver volume and the function or the expected function of the remnant liver volume. And we take in consideration, of course, the long-term outcome recurrence. That is, we consider it high if we compare resection to transplant. Sometimes we are biased towards a little bit of transplantation in this context. Our NCHAMS experience from 2001 to date, we've done 1,230 LDLT in 3 centers. The adult-to-adult living donor liver transplantation, 1,153, and just a small number of cases, pediatric living donor liver transplantation, 77 cases. When we analyze our cases and look for the HCC cases, as you can see, it comprised 32%, third of our cases being transplanted in NCHAMS, and I would say in Egypt at least 27% by the last statistics. So it's third, literally speaking, third of the cases transplanted in this country are being transplanted for HCC. And the age range, as you can see, is young, from 28 to 67 with a mean age of 52. So I think we've heard from the previous speakers that the age is really young, and this comprised the task force, and that's why it's a huge problem. And we want these patients to go back to the job market and to add to our economy. This slide shows us the journey of the different criteria for HCC cases being transplanted, starting by the landmark paper of Milian criteria back in 1996 of a single tumor 5 centimeter or transplanting 3 nodules, the largest of them 3 centimeters, and then this has been followed by the University of California, San Francisco criteria and the Chinese criteria. And then the Milian criteria challenged themselves about 12 or 13 years later in 2008, 2009 by the up to 7 criteria, the one we're trying to stick to because we sometimes have advanced cases of HCC and trying to transplant them. And it's, as could be expected, there is no wonder the further the distance, the higher the price. If you're transplanting larger number of nodules or bigger nodules, we could expect a worse 3 and 5 year survival and even disease-free survival. When we analyzed our 241 HCC cases from the group that I've just mentioned, the age range was the same with a similar mean age, and the majority of the cases, 72%, were transplanted within the Milian criteria. These are the early cases that everybody would agree in the West to transplant them. Up to the 7, again, a general agreement could have about 15%, but BAC is beyond all criteria. We transplanted 30 cases within our group beyond all criteria. That is a big tumor of 8 centimeter or 6 or 7 nodules, the largest maybe total tumor burden about 9 or 10, but we never transplanted any cases with a macrovascular invasion or with an astronomical figure of alpha-fetoprotein. Our cutoff value for alpha-fetoprotein has been always 400, and we never exceeded 400. And when we compare the 3 groups and we look for the recurrence rate and the death, and here is the overall mortality, there were no statistical difference in the recurrence rate. But obviously, the overall mortality was higher in the extended groups. The time to recurrence, or the median time to recurrence, were similar in the 3 groups. But when we look to the survival, the Kaplan-Meier survival curve, as you can see from this slide, we had in the first 1, 2, and 3 years equal and similar survival between the 3 groups, and it's only at year 5 when the up to 7 criteria started to show an inferior overall survival, and we expected it to be inferior thereafter. But at least over the first 3 to 4 years, and I would like to remember that the Milian criteria has been based only of a 75 to 80% 4-year survival. So we believe that we're offering our patients a better chance, especially the young ones, by transplanting them, even if they are beyond all criteria. Looking for the best model to predict HCC recurrence after liver transplantation, as you can see from this algorithm, where all listed patients are being followed up by CT and MRI and alpha-fetoprotein after 3 to 4 months. If there is no progression, as you can see, Here, no progression, or even if there is slight progression, we consider local regional treatment. By here, local regional treatment, we call this bridge treatment. And bridge treatment has been championed in the West for only those cases who will take time for transplant. But we bridge all of our cases, all comers, even those within Milian, because we're never sure about the timing of transplant. And then we do imaging and alpha-fetoprotein, and there is no progression with transplant. If there is tumor progression, then they drop out or delisted. And of course, for those advanced cases, we try to downstage. If the downstaging is successful by local regional treatment, we can transplant. If not, again, they are delisted. Achieving complete remission of hepatocellular carcinoma before being transplanted is of paramount importance, and this study proved that achieving this complete remission before liver transplantation results in a significant reduction of HCC recurrence after liver transplantation, independent of the treatment modalities applied, whatever you do, TACE or radiofrequency ablation, microwave, or a combination. And I would like again here to remind you that in the BCLC combination treatment has never been mentioned, although we're doing this a lot. All patients better undergo local regional therapy either as a bridging or as a downstaging, and this confirms what I've just said, that we are bridging all of our cases and trying to downstage as much patients as possible. How do we manage the recurrent HCC cases in the post-transplant setting? By all means and all armamentarium we've got. But I would like to remind you that the recurrent HCC is a unique condition because it's of a systemic nature, because of these patients are in immunocompromised state, they are immunosuppressed, and because of the immune maintenance phase of the transplant graft. And that's why we always manage these cases in a multidisciplinary setting by the transplant surgeon, the hepatologist, the oncologist. I would add also on this slide the intensivists, the anesthetists, and the radiologists, the pathologists. We all brainstorm heavily on these cases. And of course, we always try to put the immunosuppression at this stage to the minimum and to introduce the mTORs with the minimal possible CNI, which is the calcineurin inhibitors. The treatment option available for a recurrent HCC in the post-transplant setting is a surgery, whether by hepatectomy. We never consider retransplant in these cases. We think it's dangerous, but we've done, as we'll show you, several hepatectomies, local regional therapy by all its modalities, systemic therapies whenever feasible, or the stereotactic body radiation therapy, and the modulation of immunosuppression drugs is very important to put the CNI to the minimum and to add on the mTORs for its oncological benefit that we are all aware of. The site of recurrence and the pattern of HCC recurrence, it's in 25% of our cases what is intrahepatic, in 25% is extrahepatic, whether in the lungs or the bones, and in 50% of the cases it was in both actually intra and extrahepatic. How did we manage them? As you can see, we did a local regional in 13%, we did a hepatectomy in a quarter of these cases, and the chemoradiotherapy that is a local regional again, and with the systemic radiotherapy in 25%, and the sorafenib as the only, by that time it was only, now we have the other lines of treatment available, but we were still fixed with the sorafenib in 37% of the cases. This is the proposed algorithm for management of HCC that recurs after liver transplantation. We review our immunosuppression protocol, we reduce the immunosuppression, and we keep our level that used to be between 6 and 8, we keep it between 3 to 5 maximum nanogram per milliliter, because we're measuring, of course, as you know, the immunosuppression drug in the blood on a weekly and monthly basis. And we consider the mTOR for its beneficial both immunosuppressive effect and oncological effect. and we do staging by all radiological means. If it's oligorecurrence in terms of it's not disseminated everywhere, and so if it's limited to the liver, we do resection, ablation, regional therapy, or a combination of this. And if it's extrahepatic, we do some resections. We've done pneumonectomies and lobectomies of the lung in several cases, and we have a few of these cases living for 4, 5, and 8, and 10 years with the recurrence, so long that we are aggressively treating them by all means. But of course, if it's a disseminated recurrence, it's only the systemic treatment that would be available. I would like to conclude by this slide again, because it's a very famous roadmap for all those working heavily in the HCC, the famous Barcelona clinic. And I would like to say that although it's a very good algorithm comprising the patient performance status, the liver status, how much it is fibrosed or cirrhosed, and the tumor burden, and allocating them very nicely and elegantly to different modalities of treatment, and expecting even the outcome in terms of overall survival and recurrence-free survival. But in our country, we're not sticking it to this 100%, because we believe that, for example, the transarterial radioembolization has never been mentioned even in the 2017 version of the BCLC, and we're using it heavily. We believe that the combined treatment, whether TACE with radiofrequency, TACE with microwave ablation, TACE followed by TARE, resection and TACE, all this as downstaging to reach transplantation has not been mentioned, and we're doing this heavily. And transplantation have been cornered like resection in only the very early and the early stage A cases. We believe that we can extend this to include some of the successfully downstage cases who are in stage B, for example, and we can extend again the resection to include some cases being done in China and Japan, those the early stage A and stage B, even if they have a macrovascular invasion that is limited, for example, for a sectorial portal vein or something. And by this slide, I would thank you very much, and I hope that I covered it.